Okay, good afternoon, everyone. Welcome to Grand Rounds today. So it's with my great pleasure that I get to introduce Professor Paul Pavli to present today's Grand Rounds. As some of you may know, today is Paul's last clinical day at the hospital, and it sort of closes a chapter on 40 years of a very illustrious career as a gastroenterologist, researcher, educator, and a doyen of these Grand Rounds. Because it's his last Grand Rounds, I'm going to take some time just to read his bio, which is very brief, but just to give you an essence of Paul's career. So Paul's been a gastroenterologist at Canberra Hospital for the past 40 years. Yeah, his main clinical interest is in inflammatory bowel disease. Has extensive experience in all aspects of IBD, the basic sciences, clinical management, and has extensive involvement in national advocacy groups, including Crohn's and Colitis Australia. He has over 125 publications, mainly in the basic scientific and clinical aspects of IBD. In 2019, he became a member of the Order of Australia for services to medicine, to patient care, and as a researcher and mentor. As I said, Paul is retiring from patient care today, but will be continuing, and I'm sure Paul will tell you about what he'll be continuing doing. So with great pleasure, I invite Paul to the podium.
Thanks, Ashwin. What I'd like to do today is to look back over the 40 years, what it was like 40 years ago and how things have changed over that time. This is meant to be a Ruby for the 40th anniversary of my career as a gastroenterologist. Okay, so my first Gastro Society annual general meeting was in Hobart on the 11th to the 14th of March 1984, and I actually still have my my notes or my book from that meeting because it was a seminal meeting, and I'll explain why in a moment. Normally I throw those books out, but fortunately I kept this when I was doing a clean out. But since then, a lot of things have happened, and I'm going to mention some of them. Helicobacter pylori was discovered and is now a non-entity. Really, we don't have any problems with Helicobacter pylori. It's easily dealt with, and I'll show you a bit more about that later. When I was a registrar in 1983 and 1984, we had this condition called non-A, non-B hepatitis, which we now recognise as being due mainly to hepatitis C virus. And that is a non-entity these days, except for surveillance. We can now cure it. In the 90s, when I used to run the liver clinic, the treatment was terrible. It was interferon, ribavirin. Patients hated it, but now we have drugs that cure the disease. In 1983, if a patient, I'll say a bit more about this later, but what I'll talk about is interventional endoscopy. We do too many procedures in gastroenterology, and I'll talk about the futility of second endoscopies for reflux. New conditions have arisen, and eosinophilic esophagitis is one of them. The big advances in terms of gastroenterology and colon cancer have been the molecular genetics, and I'm not going to talk about that much, except to show you how relevant it is today. And we now have various genetic forms of pancreatitis that, again, I'm not going to address because that's a topic in its own right. As gastroenterologists, we spend most of our time doing colonoscopies for cancer surveillance. Again, we probably do too many, and I'll try and tell you what we should be doing. The biggest advance in my career has been the discovery and the implementation and the effectiveness of biological agents in Crohn's disease and ulcerative colitis, truly life-transforming medications. Now, my research interest is in the causes of Crohn's disease with Claire O'Brien, and really, again, that's a topic in its own right, and I don't have time to cover that. But this is the first page of the abstract booklet, and it describes the discovery of Campylobacter pylori by Barry Marshall and Robin Warren in 1984. The society recognised the importance of this in that he got the opening paper on the opening plenary session on the first day of the conference. He also got another oral presentation talking about the use of Denol, which is a bismuth containing medication used for the treatment of ulcers in those days, but which had antibacterial activity and was effective against Helicobacter pylori. Now, in this abstract, and this is the abstract in full, but this is a summary, he demonstrated that there was an association between the presence of this bacterium and chronic gastritis and peptic ulcer disease. So he found the bacterium in 2 out of 31 patients who had normal histology, 17 out of 19 with chronic gastritis, 38 out of 40 with active chronic gastritis, active means that there's neutrophils present, and 18 out of 22 and 13 out of 13 with gastric ulcers and peptic duodenal ulcers, respectively. So for any gastritis, the p-value was 10 to the minus 10, and for any ulcer, it was 5.00005. So there was a very strong association, but was this cause and effect? Had he truly shown that this was the cause of peptic ulcer disease? And that's what the discussion was. I remember really very vividly people saying, you have not fulfilled Koch's postulates. And so what are Koch's postulates? These are the criteria used to establish a causative relationship between a microbe and the disease. So what you have to show is that the microorganism must be present in every case of the disease, but absent from healthy individuals. Well, he hadn't done that because it was present in healthy individuals. And we know that only about the carriage rate is about 10 to 20% in our population. About half of those will develop peptic ulcers. So that wasn't completely fulfilled, but it was present in most cases of patients with the disease. He had to show that the suspected microorganism could be isolated and grown in pure culture. And this is one of those discovery by serendipity. They used to take the biopsies, culture them for 48 hours. If there wasn't any growth, they'd throw the plates out. So one Easter, the plates weren't thrown out for 4 or 5 days, and the bacterium grew. It was a slow-growing organism. It just happened that over Easter it grew and they discovered the organism. Serendipity strikes again. But they grew it. They then had to show that the disease must or should result when the isolated microorganism is inoculated into a healthy host, and he hadn't done that. And he hadn't shown that the same microorganism must be isolated again from the diseased host. So here we have this cartoon of the discovery. It's now July 1984. So this is just a few months after the feedback that he got from the society. He drank the brew of Helicobacter pylori. He got chronic gastritis and it went from there. It's not just peptic ulcer disease that's associated with Helicobacter pylori, it's gastric cancer. And there are many studies now that show that infection is associated with an increased risk of gastric cancer. 90% of gastric cancer is attributable to HP infection, and the other facultative factors have a minor or no role. And this is where we are today. The global prevalence of Helicobacter pylori is falling. Gastric cancer is falling in all countries around the world. These are the prevalence, the darker the colour, the greater the prevalence. And you can see the global prevalence here in the top is falling. Gastric cancer incidence rates for men and women are falling, and whichever subpopulation you look at, it's the same story. So Helicobacter pylori, I won't say it's a non-entity, but it's solved. The problem is solved. All you've got to do is treat with a course of antibiotics. There might be problems with resistance and so on, but it's not too hard to cure patients with Helicobacter pylori. And as you all know, Moran and Marshall were awarded the Nobel Prize for the discovery of Helicobacter pylori. Now, at that same meeting, the main themes were peptic ulcer disease and the mucosal barrier. Again, we hardly see any peptic ulcer disease these days, whereas in those days we had patients, we had wards full of peptic ulcer patients. We didn't have any effective treatment. We didn't even know what the cause was. The other thing that was addressed at the conference was hepatitis B and gastrointestinal motility. There were only 4 presentations on omeprazole, the first proton pump inhibitor, which is only just starting to be used in 1984. There was one talk on polyp surveillance, just one talk, and that was a single centre experience of colonoscopy and removal of polyps. There was one presentation on inflammatory bowel disease, and that was actually a basic science presentation, and that in those days, the only treatment for IBD was steroids or surgery. There were no presentations on on hepatitis C or non-A, non-B. I just have to put in a plug for Jeff Farrell, who also spoke, and Libby Hillman, Canberrans, who spoke at that meeting. A quick word on hepatitis C. In 1999, when I was running the liver clinic before the late, great Graham Kay came, this was the outcome of patients infected with hepatitis C. Chronic hepatitis in about 80%, 20% developed cirrhosis, and liver cancer in 4 patients. So significant numbers of patients develop cirrhosis and may or may not have developed liver cancer. In 1989, the virus was discovered, and in 1990, blood was first screened in Australia for Hep C. In 2014, the first curative combinations of direct and acting antiviral drugs became available and were approved. And this is another Nobel Prize winning discovery to the people that discovered the virus in the first place. Now, the first handy hint, population prevalence of hepatitis C is 3%. It's quite common. Significant numbers of patients will have cirrhosis. These patients need to be followed up. They need to be on a surveillance program. We can cure the hepatitis C, but patients who have developed cirrhosis are at risk of developing liver cancer. And these patients should have abdominal ultrasound and alpha-fetoprotein every 6 months. But that's not just for Hep C, it's for all cirrhotic patients. We now can resect early liver cancers, and whatever the cause of cirrhosis, they do need to be on surveillance so we can get the hepatocellular cancer early. Gastrointestinal bleeding, I was a registrar at Concord in 1983. If a patient came in with significant bleeding, it didn't stop, that patient went to surgery. We didn't have any intervention available. I went to North Shore in 1984. Tim Heap was a therapeutic endoscopist, introduced injection for bleeding ulcers. And that's really changed the treatment of bleeding ulcers. Kavitha's here, but she was just doing an intervention on a patient an hour or so ago. Now, we know that the causes of ulcers are Helicobacter, I've already said it. The other major cause are NSAIDs, and that's virtually it, really. The rest are very small numbers, some drugs, and incredibly rare, or rarely cancer. Now, people with ulcers, or ulcers can rebleed, and we can look at an ulcer and say that that's a low likelihood of rebleeding, and that's a 30 or 40% chance, and that's an arterial spurter, and that's not going to stop until you do something about it. So there's a risk of rebleeding. And the risk of rebleeding is increased by antiplatelet agents and anticoagulants. So what do we do in a patient who comes into hospital on anticoagulants, on antiplatelets, who've had a bleed? Do we stop or do we continue? And this is, again, a very important paper, but it's just one of many. This is the risk of rebleeding of vascular events, thrombotic events, and death after GI bleeding in patients on anticoagulants and or antiplatelets. And it looks at 90-day recurrent bleeding, thrombosis, and death, and 6 years. So this is 6 years, recurrent bleeding, thrombosis, and death. There's no real increase in bleeding within 90 days, but there is, even within 90 days, an increased risk of thrombosis and an increased risk of death in the people that are not put back on their antiplatelet agents. And this is even greater at 6 years. So handy hint number 2, and this is really very important. If a patient comes in with a bleed on antiplatelets or on anticoagulants, you should restart those medications. And depending on the nature of the bleeding vessel, the bleeding ulcer, within a couple of days or within 7 days. Clearly, you need to discuss the indications for the antiplatelets or the anticoagulants with the doctors that initiated therapy, but almost always it's safer to resume those agents. We can normally control gastrointestinal bleeding. We can't do much once a person's had a stroke or a heart attack. And this is relevant for both upper and lower GI bleeding. Now, I've mentioned proton pump inhibitors. They were just starting to be used in 1984. And we spent a lot of money on proton pump inhibitors. This is the top 50 PBS medicines by the number of scripts and the total cost. And you can see that we spend, the government spends about $150 million and another $50 million from patients. So over $200 million are spent on proton pump inhibitors. Are they worth it? And what are the risks? This was my typical Wednesday morning endoscopy list at Court Hospital. Dilatation, 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 dilatation. These are people with esophageal reflux and strictures. They would get dilatation. We never had wanting to. Dilatation, dilatation, dilatation. And this is because we couldn't treat reflux properly and people were getting reflux strictures. Now, we won't talk about infection control in those days, Ashwin, but you can just imagine what it was like if we got through 18 procedures using the same scope in the morning. Okay, so they're effective. We don't see people coming in with esophageal strictures anymore. But there's a lot of stuff out there about the risks of proton pump inhibitors. And this is really the definitive paper as far as I'm concerned. This is a big study, 1.9 million people, and what was the mortality risk of PPI therapy? And they did this because observational studies link PPIs to increased mortality and poor outcomes like dementia and so on. But these studies are prone to reverse causality, where the deaths are attributed to the treatment rather than the conditions being treated, and that's called protopathic bias. What that means is that conditions with high lethality are associated with the use of PPIs to prevent bleeding. And so you're blaming the treatment instead of the underlying condition for which they were put on that treatment. And for example, people in nursing homes and in hospitals, they get put on PPIs for stress ulcer prevention. Dialysis patients get put on PPIs, and patients taking anticoagulants get put on PPIs, liver cirrhosis patients. So it's the underlying condition that is the problem, not the drug. So what did they show? 80,000 people died during the follow-up of 1.9 million people. The unadjusted death rate was 14.3 for PPI users and 7.9 for non-users. So there was a clear 10% increased risk of dying in patients on PPI therapy. But when you took away the patients that had been started on the PPIs within 90 days of the death, there was no increase in mortality. So people who are on it long term are okay. It's the people that you start on for whatever the underlying condition is that are dying from the PPI therapy. And you can say that many epidemiological studies on the use of PPI therapy are flawed. because of this protopathic diet. I just saw a paper the other day saying that migraines were associated with basically all acid-suppressive agents, including antacids. Now, I can't see any pathophysiological process that would tie in H2 receptor antagonists, antacids, PPI therapy, and migraines. But you know, so there must be some sort of epidemiological flaw there. So in terms of balancing the risks and benefits, PPI therapy is safe and effective, but step down to H2 receptor antagonists if you can. And you've got to tell patients that you don't need acid to digest your food, because patients all stop their PPI therapy because they think you need it. Otherwise, it'll affect their digestion. Okay, reflux disease. I might just skip through this because I think Ashwin wants a few minutes at the end. But the bottom line is we rescope these patients for esophageal cancer. And do we need to? This is a study. I'll cut to the chase. The bottom line is that the risk of people who have non-erosive, so there's in the previous slide, non-erosive gastric reflux compared to those who have erosive gastroesophageal reflux, the risk of non-erosive reflux of developing esophageal cancer is no different from the background population. For erosive esophagitis, it does rise, but look at the rate. 11 per 100,000 patient years, 1 per 10,000 patient years in non-erosive, 3 per 10,000 patient years in erosive reflux. The risk is very low. Do we need to do scopes in these patients? If a patient has reflux and their symptoms recur, check compliance, and generally they stop their medications and restart them. If they have dysphagia, you might refer for reassessment. The people that we do follow up are the people with Barrett's esophagus, which is metaplasia, affecting the lower esophagus as in response to the ulceration. It affects 5 to 6% of the population, but even in those patients, the risk of cancer is low, but they're the patients that we do follow up. This is a patient with eosinophilia esophagitis, typical endoscopic appearances. He's coming with dysphagia, intermittent dysphagia for solids. This is a new illness. It wasn't around even 20 years ago. We've learnt a lot about it. And if we take biopsies, we can see lots and lots of neutrophils in the esophagus. There's a background of atopy, asthma, eczema, and hay fever. So if you see young people have intermittent swallowing problems, especially if they're atopic, they could have eosinophilic esophagitis. I want to get on to bowel cancer screening because that's what we spend all our time doing. I briefly mentioned that we know a lot about the molecular subtypes of colorectal cancer, and we've characterised them pretty comprehensively. And we can work out whether various mutation suppressants. So this patient had KRAS negative, NRAS negative, but it was positive for BRAF. And now we can actually say that this patient will make the response to these agents highly unlikely. And so we can actually tailor the treatment of the cancer to the underlying molecular pathology. And we're doing it with breast cancer, but we're doing it for colon cancer. This is a routine pathology report. So that's how far we've progressed in terms of colorectal cancer. But the big thing is colon cancer is a preventable disease. And that's handy hint number 5. Sorry, just go back, get rid of that. We've recognized adenomatous polyps for years, but these subtle lesions called cess-ulcerated polyps have only really been recognised since about 2010. If we regularly remove those lesions, we can prevent bowel cancer. Bowel cancer, second most common cause of cancer for men and women. The commonest gastrointestinal cancer, here we see all of the others down here. It's got a 70% 5-year survival, and I'll come back to that later. Bowel cancer is uncommon in people under the age of 50, but then starts to take over starts to rise from the age of 70. Our screening program actually stops at 75. The risk is higher in people older than that. So a 50-year-old man or woman has a 1 in 10 chance of developing bowel cancer by the time if they live to 84, and 1 in 15 for women. So what are we going to do about it? Well, the first programs for population screening were in the early 1980s, and this is one of the original studies in 1983 in the Lancet. And basically these studies, you're looking at FOBT population screening, had a risk reduction of developing colorectal cancer of 30 to 40%. And most studies show FOBT being that effective. The big problem we have with FOBT and all colonoscopy, colon cancer screening programs is compliance or participation rate. People don't like going through the processes. And this is a study just published last year, looking at comparisons of different modalities, and this is a very comprehensive review of the literature, all of the randomized controlled trials, simulation models, and they looked at all-cause and CRC-specific mortality in colorectal cancer screening. And what they showed was that second-yearly immunological testing, fecal occult blood testing, a single or 5-yearly sigmoidoscopies or 10-yearly colonoscopies reduced cancer-specific mortality. And of all of those, the 10-year colonoscopy was the most effective, with a mortality reduction of 73%. So it seems that that's the most effective, but that's obviously the most expensive and the one with the greatest risk. Now, colon cancer specific mortality is one thing, but what about all-cause mortality? How good are the various cancer screening programs in reducing all-cause mortality? Now, this is going to be pretty hard because I said that a 50-year-old has got a 10% chance of developing bowel cancer by the time they reach 85. And the survival of bowel cancer is 70%. So we've got 30% mortality in the 10% of people who are going to develop bowel cancer. So you're going to have really large numbers of studies before you can actually show an improvement in mortality. So these are the various studies that were looked at. And these are the number of trials, the number of subjects within those trials, and the follow-up duration. And what they showed was that basically nothing except sigmoidoscopy improves all-cause mortality. Sigmoidoscopy in 4 trials of 250,000 people improved lifetime gained by 110 days. Now, the problem with this is you'd think that colonoscopy would be better than sigmoidoscopy. The trouble is that there's only one study with a relatively small number of patients. So I think we've got to take that into account and assume that colonoscopy is probably even better than sigmoidoscopy. So again, I want to point out the difference between all-cause mortality and cancer-related mortality, which is improved by all of these screening tests. Now, there are many studies that show this, and this is basically showing that colonoscopy every 10 years decreases your risk of developing bowel cancer. And this was a German registry, and they looked at patients that had had 2 screening colonoscopies, one at roughly the age of 55 and a second one after the age of 65. And in their registry, they found 120,000 patients who had had 1 and then a second colonoscopy. And they looked at the risk of developing bowel cancer in the interval and compared it to 1.25 million people who had their first colonoscopy done over the age of 65 to see what the difference was. And this is for men. I've cut it down so you can actually read it. But basically the risk is percentage, 0.3% of men who had the second colonoscopy over the age of 65 with an interval of 10 years developed bowel cancer. That's the different breakdown of the age groups. And if the interval was more than 10 years, it was slightly higher, but still very low. So basically, if you have a colonoscopy and you don't have any, high risk lesion, then the risk of developing cancer within 10 years is 1 to 5 in 1,000. And the prevalence ratio was reduced by 80%. I won't go through this because I've talked about this at Grand Rounds previously, but our figures are post-colonoscopy colorectal cancer risk is less than 2 to 300,000, which fits in with the data. And that is, I said, bowel cancer is a preventable disease. The corollary to that is you should screen from the age of 50 at intervals of 10 years and possibly longer, unless you find advanced polyps. And these are the Australian Cancer Council guidelines, and 0, 1 or 2 polyps. You can leave 10 years between examinations. If you have large polyps or large advanced polyps or large polyps, then you get them removed. And that way we can prevent bowel cancer. I'll say a few words on Crohn's disease in the 2 minutes that remain to me. It shouldn't be called Crohn's disease. The person who first described it was actually a surgeon from Glasgow called DL. And he described chronic interstitial enteritis affecting the terminal ileum. And he basically said that this is a condition that is not tuberculosis, because there was a lot of tuberculosis around in those days. And he was the first person to describe it in 1913. Now, the course of Crohn's disease we understand quite well. It starts off as aphthous ulcers in the neoterminal ileum or in the colon, and they become confluent and you get more significant ulceration. And then finally you get scarring, fibrosis, stenosis, and you can't do anything to that patient except remove that bowel. Now, again, you want to know what the latest is? This is the latest, February 2024. This is a game changer. This is a study from the UK. They looked at top-down versus accelerated step-up treatment using biologics. Newly diagnosed patients, most patients were actually treated within 15 days of the diagnosis of Crohn's disease. You make the diagnosis, within 15 days they're on the trial. And basically what they did was they put all patients on steroids, which I would argue was not necessary, and they either started infliximab or they started the immunomodulator, Imuran or methotrexate, or they did the accelerated step up, which is generally steroids, wean, steroids plus immunomodulator, wean, and then if they failed that, they went on to an anti-TNF agent, infliximab. If patients on infliximab had a flare, they'd get a course of steroids, and if they had a second flare, they came off the trial. So these are the results, and these are astonishing. 80%, nearly 80% of people on this trial went for 48 weeks without, they were steroid and surgery-free. They were in steroid and surgery-free remission at 48 weeks. Remember, in 83, the only treatment was steroids and surgery. We've come a long way since then, and it's made such a difference to people's quality of life. Only 15% of the patients on the standard step-up approach actually were in steroid and surgery-free admission at the end of 12 months. This is endoscopic healing, which is our goal. 67% in the top-down, aggressive, early introduction of anti-TNF agents. 44% of the step-up were in endoscopic admission, but 41% of patients who were in that arm actually went on to anti-TNF agents anyway. So a lot of this is due to the anti-TNF agents. I'll just point out surgery for disease, much higher in the step-up group than in the top-down group. And there was the adverse events were basically flares of Crohn's disease, but there wasn't really much difference in terms of the infections, which is our major concern. Now, these drugs are expensive, and this is, again, the PBS. I like the PBS cost pages because that puts things in perspective. We spent $1 billion total cost on the biologics. That's not just for IBD, it's for all of the rheumatological and dermatological and malignant conditions as well. $1 billion on IBD. Sorry, these agents aren't used just for IBD, but rheumatological and dermatological, but the other biologics we use for other conditions. Apologies, but $1 billion on the anti-inflammatory biologics. But they're becoming cheaper, and now you see Humira is less than $1,000 per script, and you need about 12 scripts a year. And so what that means is that for yearly costs of infliximab around $7,000, and for Humira adalimumab around $10,000. So handy hint number 6, introduction of anti-TNF agents as soon as possible after the diagnosis of Crohn's disease leads to the best outcomes. So I'll just go over those handy hints. And just to remind you, we need to put all patients with cirrhosis on surveillance programs. If you do have a patient on antiplatelets or anticoagulants, restart them, whether it's upper or lower gut bleeding, unless the cardiologist or neurologist says you don't need to. PPI therapy is safe. They're flawed because of protopathic biases. If you need to take them, but if you can step down, you should. We don't need to do regular endoscopies for esophageal cancer in erosive or non-erosive reflux. Colorectal cancer is a preventable disease. On a population basis, I think the only test we can really use is the FOBT or FIT, but on an individual basis, the best screening modality is colonoscopy at intervals every 10 years. And early introduction of anti-TNF agents is useful. So I'll stop there and invite any questions. Thank you.
Okay, we've got a couple of minutes for questions for Paul. We've got a couple of microphones here too. So we've got Fabian.
Thanks for the amazing talk. So what is the gold standard for colorectal cancer screening? Is it colonoscopy or is it CT colonography or?
So the question is, what's the gold standard for screening? Like I said, on a population basis, I think you have to go with the fecal occult blood testing. But if a patient comes to talk, expresses concern about the risk of colorectal cancer in that particular patient, I would recommend colonoscopy every 10 years. CT colonography is improving, but it's not quite there yet. The problem is if you get remaining poo, you can't tell the difference between adherent poo and a lesion. And the other thing you've got to remember is that those sessile serrated lesions are very flat. You can see them, and in fact, we're better at picking them up because we're better at cleaning the bowel, and we've got better instruments that enable you to visualize the mucosa more effectively. But you're never going to see those on a CT scan.
Yeah. Is there another question from the audience or online? Let's see. I might just ask one, Paul, just if the chair's prerogative. So 40 years of distinguished practice, so a real example of how to lead an exemplary and distinguished career. So we've got lots of students and BPTs and other early career people here, clinicians. What's your advice for the next 10 to 40 years?
Okay, 40 years. I could do it for another 10, but I've decided not to. You've got a long, long career ahead of you. You've got to vary it, really. If you want to go off and do a gap year, travel for a year or two, do it. If you want to do a research degree, do it. If you want to take time off and have a family, do it. 40 years is a long time.
Okay, thank you, Paul. I might invite Nicole Goddard to the stage. So Nicole's our chair, convener of the Grand Rounds. We just would like to pay tribute to Paul for his extensive contributions to Grand Rounds. So,
Thanks, Shredding. Thanks, everybody. Before we all brush off, Paul, we'd just like to present you with this small token of appreciation from the Canberra Hospital and Grand Rounds. This is really to recognise your amazing commitment to Grand Rounds over the last 40 years. Paul, I think as anyone who's regularly attended this meeting knows, has been such an enthusiastic participant both behind the podium and has presented on a very regular basis, as well as hosting Grand Rounds in the past, advances in clinical practice. He used to run the quiz, Grand Rounds quiz at the end of year as well. But also not only behind the podium, but in the audience, always encouraging, a stimulating discussion. And so you'll be greatly missed in our audience in future. And I think just echoing Ashwin's sentiments, that I think Paul set such a shining example to us of how to really balance clinical excellence with clinical service, as well as medical research, and also such a strong commitment to continuing medical education. So we will miss you, but congratulations on your retirement from clinical medicine. And we know you'll have a very exciting next chapter, and your family will probably be delighted to not have to share you so much with the hospital. Thank you.
Thank you.
I'll just quickly also say, so the plaque says, to Professor Paul Pavli, in recognition of your steadfast commitment and contribution to Grand Rounds at the Canberra Hospital, thank you for your passionate support of clinical excellence, research, and for keeping us all on track with presentations that even our Oxford and Harvard colleagues would be interested in. It's a bit of an inside joke because we always have to try to reach that benchmark.
Yep.
I think we're going to have to let Paul go because he actually has clinic to finish up. But Shiv, sorry.
Paul, happy birthday today.
And so also that was supposed to be a sneaky secret, but Paul is not only doing clinic on his last day, presenting Grand Rounds, it's his birthday today. Sorry.